Hello, let's learn about environmental infection. Identifying what are the objectives? The objectives include identifying hazards that could potentially compromise patient care, implementing proper controls to reduce risk and minimize the impact of various environmental pathogens with more virulent microorganisms transmitted from colonized or infected patients or staff. Infection control therefore includes the prevention of contamination and colonization as well as direct infection to limit the spread of infection. Environmental rules and sources include air, water, medical equipment, environmental surface, food and drink. The potential routes of transmission of nosocomial infections involving the environment are contaminated equipment, colonized patients, contaminated hands of healthcare professionals, susceptible patients, contaminated air, and direct patient-to-patient contact. Now, the airborne organisms can be inhaled, fall directly into wounds or instruments, or survive on surfaces, and then can be indirectly transmitted to patients. Airborne transmission occurs when a patient inhales droplet nuclei of less than 10 microns or small particles containing microorganisms. Droplet transmission occurs with large droplets of more than 10 microns. They originate mainly from oropharyngeal secretions in the upper respiratory tract and contaminate a susceptible host either by impaction on mucous membranes at short distances less than 1.5 meters or indirect transmission by contaminated fomites. The main droplet-borne microorganisms or airborne organisms in the hospital include Staph aureus, Coagulus nigra, Staphylococcus, and Streptococcus pyogenes. Measures for the prevention of this airborne transmission in operating rooms and other high-risk environments include repeated air changes, air filtration, and reduction of air turbulence, keeping staff to a minimum throughout an operation, and limiting the door openings and movements in and out of the operation room. Maintain the airflow directed from the clean areas such as operation rooms, ICUs, and treatment rooms relative positive pressure to less cleaner general areas such as relative negative pressure. Then applying stricter measures for high-risk environment. For example, 6 air changes per hour can be recommended for general wards, 10 changes for critical areas, 15 changes for operating rooms, and 25 changes for general operating rooms. Using laminar flow filtered via air by canopies such as ultra-thin ventilations for proceeding impedance. The criteria for operating room air quality includes empty operating room that is 35 less than 35 colony forming units per meter cube with less than 1 colony of Clostridium perfringens or Staph aureus per meter cube. During an operation, total air counts less than 180 colony forming units per meter cube averaged over 5 minutes. The remark about tuberculosis. Identify the infected patient. This is essential as undiagnosed patients can spread the disease widely in the institutions due to confined air and duration of contacts. Assess the risk for drug resistance and HIV for all patients with tuberculosis. If multi-drug resistant tuberculosis is identified, special precautions should be implemented. Limit the contact of patients with suspected acute tuberculosis with other individuals, especially immunocompromised patients, until judged to be non-infectious. Implement airborne or droplet precaution by using protective respiratory equipment. In patients with tuberculosis, wear a surgical mask whenever they leave the rooms until they have considered as non-infectious. So MDR to TB can be should be isolated in negative pressure ventilation rooms with a higher level of. The prevention and the control measures include implementation of droplet precautions, appropriate management of symptomatic professionals, administration of influenza vaccine, hand washing measures, rapid screening and cohorting of patients on admissions, cohorting of the ward staff, and limiting the family visits, and use of gown and gloves. The preventive and control measures include strict IPC practices, that is, infection control practices, for Middle East respiratory syndrome and other high-risk coronavirus. Strict IPC practices, staff education and the potential risk of patients with MERS being admitted. Strict IPC practices maintained by all staff at all times. Enhanced production, that is, negative pressure ventilation, and use of personal protective equipment for suspected. For norovirus, keep the symptomatic patient and staff out of the hospital where possible. Enforcing strict contact precaution until 48 hours after symptoms are cleared. Restricting the patient movement and reinforcing hand decontamination and environmental cleaning. For waterborne transmission, in hospitals, environmental water contamination has led to many hospital outbreaks. This includes Legionella outbreaks, outbreaks of gram-negative opportunities in high-dependency units due to contamination of tap water and humidifiers. Pseudomonas outbreaks associated with medical devices or hydrotherapy full. Regarding Legionella, the risk of Legionella outbreaks can be reduced by installing safe water systems and equipment and implementing preventive maintenance programs. There are extensively regular requirements for the control of Legionella, and hospitals should be compliant with the guidelines. The principles of prevention and control of Legionella include the hospital should produce a Legionella policy, assess the risk of contamination, implement appropriate risk reduction programs, monitor the compliance, rapidly identify cases, and investigate and control outbreaks. A named person should be manager responsible for the Legionella outbreaks management. Water system installation and preventive maintenance programs should avoid water stagnation. Store and distribute cold water below 25 degrees Celsius. Maintain hot water temperature at a high enough level to kill Legionella. Include a program for de-escalation and biocide treatment. Include regular flushing of the taps. Monitor regional concentrations and treatment. So let us open Legionella regarding multi-drug resistant gram-negative organisms. Any water distribution point not in use should be removed or at least kept away from the patient. Disinfectant should be freshly prepared. Standing water sources such as ice machines, water baths, humidified water should be replaced regularly. There are specific guidelines on the control of contamination of specific items and facilities such as hydrotherapy pools, express breast milk, and the ionized water others. In other cases, appropriate cleaning and disinfection between each patient is effective. Disinfection of larger equipment such as ventilators and incubators in hydrogen peroxide rooms is useful. Prevention and control measures. Decontamination of fiber optic endoscope is a specialist procedure and that should be performed only by trained personnel. There are often local regulatory requirements and different instruments and automated washer disinfectors, which may have different manufacturer procedures. After cleaning, flexible endoscopes can be disinfected by special chemical solutions or by rinsing and drying cycles. An enzymatic treatment is also commonly used to remove bio. Hospital setting outbreaks may frequently be associated with medical devices, in particular fiber optic endoscope or heaters, coolers during cardiac. Successful disinfection depends upon correct operation of the automated washer disinfector, use of an appropriate disinfector at the correct concentration, and use of clean water for the final rinse. A weekly test of the quality of the final rinse water should be considered. Quarterly and annual tests that include prolonged incubation needed to identify the contaminated mycobacteria. If higher TVCs are found, then should go for a self-disinfection cycles. Dry surface contact transmission. There is increasing evidence of the role that environment plays a role in hospital-acquired infections. Survival of hospital pathogens on dry surfaces have been observed. Microorganisms such as Acinetobacter, Clostridium, Enterococcus, Pseudomonas survive from days on environmental surfaces. The surface environment around colonized or infected patients is frequently and often intentionally contaminated with hospital pathogens. Contact with the room surfaces or medical equipment frequently leads to contamination of the hands of the healthcare professionals and patients. So to have an overview of the common routes of transmission and potential strategies, this includes ICU room surfaces should be disinfected, known infection or colonization patients should be segregated, portable equipment needs to be disinfected, hand hygiene should be followed, susceptible patients need to be observed for infection control measures. The patient admitted to the room previously occupied by patient colonized or infected with nosocomial pathogen has the highest risk of acquiring that pathogens. Hence, environmental cleaning should be stringent. Improved environmental cleaning of wards and terminal cleaning of isolation rooms, it should decrease the infection rates. This has been shown in several studies. Improved terminal cleaning of the isolation rooms after the colonized patient discharge and before the next patient is admitted leads to reduced infection rates. Human papilloma decontamination reduce the proportion of rooms contaminated with MDROs by 35%.